This is Dr. Amy Ho, host of ACEP Nowcast. Before today's episode, we want to remind our listeners that registration for ACEP's 2026 Scientific Assembly is now open. Your specialty, your people, one place. Join us in Chicago this October and register now at acep.org/ACEP26 for free access to ACEP anytime.
Ryan Stanton here with ACEP Frontline, and today we are joined by two folks. A very topical discussion today, talking about the experience of aortic dissection and the detection of aortic dissection. And of course, if you've been following the news with a recent passing of a senator and the discussion that he passed away from a dissection, this is a very timely discussion. So joined by Brian Brantley, a survivor, and Dr. Rob Ohle from Canada, who's developed some clinical decision tools that we have within the POC portion of ACEP. And so we're going to talk about aortic dissection. And Brian is a survivor of a type A and B dissection. And, so pretty important piece there. And clearly things turned out well with the fact he's on the podcast with us today. So let's first kind of get a background on you. Brian, tell us a little bit about yourself.
Sure. Originally from Philadelphia, Pennsylvania, worked in the sports industry. I work currently the VP for Advancement for the Rose Bowl Legacy Foundation. And but at the time of my dissection, which was May 12th of 2017, I was working in athletics for Cal Poly up in San Luis Obispo, California, the Mustangs. And it was one of those things that, you just, obviously, I didn't even know what a dissection was. So when it happened, everything was kind of like a New York minute and how fast it was. So shout out to French Hospital and Dr. Canvasser, my heart surgeon. But they were truly amazing people, and they have a cardiac center. And from that point on, it's been 9 years, and it's not lost on me. The more information that I learn about dissections and the survival rate and all those kind of things, and detection, and all those kind of processes as I've gotten older and time's moved on, it's pretty amazing. And that's why I'm also on the board of the John Ritter Foundation. And John Ritter, the amazing actor, and his widow, Amy Yazbak, and started the foundation with his sons. And being a part of that is really special, and being a part of that board.
So it's an important discussion to make, and for those that are young out there and don't understand a New York minute, a good Eagles reference to exactly. A New York minute when everything can change.
Yes.
It's a great song if you haven't heard it. So let's kind of dive in, and we're buying a little bit of time because Rob's up in Canada, and we will get him back in a second. Apparently, they shut down Canada for a second, but it's going to flow with the natural flow of what we were going to do anyway. So tell us your experience with aortic dissection. Kind of lead us up to that moment.
Sure. It was honestly, Dr. Stanton, it was one of those things where you really now know. I know when people say, be present and talk, to your loved ones and all those kind of things. I have, real life experience with that now. And so it was a normal day. I had a morning meeting with folks there at Cal Poly. I was just about to get in a car and drive to Vegas for a wedding. It was a Friday. It was Mother's Day weekend. And I went downstairs, I say downstairs on campus, the athletic building, went down to get something to eat. And just to get something to snack on in the car for the drive. It's a 5.5 hour car ride, and out there. And I was going to stop in Bakersfield, get some lunch, and then keep going. Went down and bought a couple of snack things, and I took a couple steps, and the worst pain I've ever had in my life on my chest. And it's just somebody took an anvil and just dropped it on my chest, and it just kept squeezing and kept squeezing and kept squeezing. And I'm like, oh my gosh, I don't know what this is. This doesn't feel so good. And, I was like, oh, I'm okay. But I told myself, don't go down in front of the students. The students were walking around. I didn't want to become a meme. And I just, but it buckled me, and I knew something was wrong. But typical, old school way of thinking. Rub some dirt on it, you're fine. It's just probably, really bad heartburn or something. But it felt like there was still like somebody had their foot on my chest. I said, no, let me go outside, get some air. Walked outside, got a little air, and I said, no, let me walk back over to the athletic building, and on the lower floor is where our athletic training is for the athletic department. And I got to give a shout out to Crystal Slover, because she's the head athletic trainer there. She saved my life. She was the one. I was just going to ask for some Tums or something, and she proceeded to kind of gate check me and put me down and said, hold on a minute, let me see what's going on here. And she took the time and to ask some questions, even though I didn't want to ask questions. I wanted to get on the road and go to the wedding. So but she convinced me to go to French Hospital there in Slough, which was a cardiac center. And then get there, the EKG, checking it out. And then they took me back for a CT scan. And then that's when everything kind of, that New York Minute kicked in. And before I knew it, I'm on the gurney. Dr. Canvasser, my heart surgeon, came over, and, it got real fast. And I was by myself, and, I believe it was like around 11 hours later, they finished with me, and it was the middle of the night, and all that kind of stuff. And then I woke up that Saturday, or they woke me up, I guess, in ICU. And I remember I was so heavily sedated. I had no idea how much time had passed, but I knew something had happened. And I remember I couldn't move anything, but I could see my feet. And I'm like, I'm alive, I think, and it was something that, I didn't really understand what had happened. I really didn't understand in the moment. And then that just, kind of progressed from there. But just coming from that, and that's why I think you, and when we get Dr. Ohle back on, and you, the two of you, I would give you a big old hug, because you're saving people's lives. Stuff like this breaks out. And I can't say thank you. I can give you a Starbucks gift card, but I can't. What do you say? What is to folks like yourselves who are on the forefront of this, and for many of, I guess, of us survivors who are just trying to understand what happened, why it happened, all those questions that we have. So yeah, I'm interested to learn from both of you today, and understand, because it really is. It's still new. It's been 9 years, and I'm still growing and learning from everybody has a different story about whether they survived, and for those unfortunately who didn't make it, everybody's living in their own movie, and it's so one way or the other, and it's mind-boggling. It really is.
That's interesting, because, it's the last dissection that I had. Actually had a group of weeks where I had one every single week that came in. But the first one just came in with just his chief complaint was leg spasms. And there was no chest pain or anything like that. It's just the treatment of the symptoms and the progression just raised the suspicion enough that we eventually got that scan done and got the diagnosis. But you talk about, in medical school, they always tell us that it's a tearing chest pain that slowly moves its way down towards the, chest down to the abdomen, and things like that. You mentioned yours like an anvil sitting on your chest. Now, did it evolve, or did it kind of stay in that same area the entire time?
Yeah, what I remember, Dr. Stanton, is it was on my chest, and it was like chest like hard, and it still felt like that. And I think it moved to my back. I think it went from the front to the backside, and if I remember correctly. But I remember sitting, and I know it was weird, because the weight of it on my chest had me sitting forward and leaning forward, and I didn't really catch that until later when I was thinking about the whole thing and leaning forward. I think I was, in some subconscious way, I was trying to get the weight off my chest that was pushing down, and it was something that as I was leading up to it, I remember Dr. Canvasser, put his hand on the leg and he said to me, he said, like, we can do this here at French, or we can life flight you to Stanford to do it there. And I, again, I was by myself, so I had to make this executive decision. And I said, no, here's okay. Here's okay. And he just said, yeah, you're in good hands. He said, but you probably want to call somebody, and again, not knowing the severity of it and understanding any of it until much later. I knew it was bad, but I didn't know how bad, and the pain structure that was happening in my chest. And then when they said, yeah, we're going to have to go in now to the heart and get this going quickly. I knew I was in for something. I knew I had done something wrong at that point. But the pain part of it, though, was pretty much front side to the back side, and then that was it. Like, I didn't feel anything in my legs or anything like that, or my arms, but it was definitely all of my chest was kind of lit up pretty good.
And that's the challenge with this, is it's difficult. We're taught based on what the book tells us the symptoms are going to be. And then there is the realities of the human condition of which people present. And that's why, it's going to take a minute for AI to replace physicians, is because, there's not everything presents in a way that is linear and 1 + 1 = dissection. It's everybody has a little bit different experience. And I think we saw that with John Ritter, that came in and with his type of dissecting back into the towards the heart itself and causing EKG changes and findings consistent with an ST elevation, myocardial infarction, took him up with that type of diagnosis in mind. And that's the big challenge for us, is the fact that many of these, especially type A dissections, they look like a heart attack. Well, the challenge is the treatment of this is very different than the treatment of a heart attack. And if we treat 99 heart attacks, maybe one of those, then you have +1 that's going to be an actual dissection. And so it is kind of that index of suspicion of, does it make sense? Is there anything else there? Taking a little bit deeper dive before we get them up to the cath lab. So talk to us about your interactions now with the John Ritter Foundation and what you're trying to do, with that organization, with this being a relatively rare, but not super uncommon diagnosis.
Yeah, the John Ritter Foundation, and again, I'm just honored to be a part of them and be with them. They're just truly amazing people all around, and it really is. They're looking at it as education, not only for the patients, but also the doctors and the healthcare folks, because they think. Because again, you just mentioned it, like, it looks like a heart attack, and I think that's what is what happened in John's case, and to be able to have the education and the awareness, and then the resources to help folks go through and understand what dissections are and what causes them, or what the potential cause of them, and just make sure that there's the correct information out there. Because I think a lot of times, even my friends and family, I think, we're like, oh, heart attack, immediately think Widowmaker and things like that we've heard, from when we're little, but not too many times do people talk about dissections and understanding them. And now that, the unfortunate thing with Senator Graham earlier this week, just bringing it to the forefront again, like John's did. It's a good time for awareness and understanding of what the dissection is, and that's where I think the John Ritter Foundation is a really key piece to help, for a resource. People can go there. Great website with information to go in and understand, and again, not only just for people like myself who are survivors, but family, friends of people who might be survivors, or somebody who may have unfortunately passed away, to just understand what's going on. And because again, it's not in the everyday lexicon of health challenges is a dissection. It's as you said, is relatively rare, but I think it's more known now than ever.
Yeah, we remind these are, a lot of times these are the low frequency but high intensity or high impact type diagnoses that we don't see a ton of, but when we do see them, that it's something that kind of goes zero to panic alert relatively quickly. And the good news is Canada has entered the chat. We've turned back on Canada and gotten Rob back. The bad news for you, Rob, is that you're going to have to listen to the rest of the podcast on your favorite player to get the entire story that Brian experienced. But, the way he's described it is, he's sitting there at work about to make this transition, this drive to Las Vegas, and develops this pain on campus that's feels like an anvil sitting on the chest. And thankfully there was a trainer there that took it seriously and it kind of worked to get that care. And we talked about, the challenge, not only of the diagnosis, of the fact that, looks very much, especially with John Ritter, how it resembles a STEMI, but is very different, relatively different in terms of the management. So, Rob, give us a little, your perspective as a physician. First and foremost, tell everybody a little bit about yourself, and then dive into your perspective of the challenges facing us with regard to aortic dissection.
Yeah, thanks, Ryan, and thanks, Brian, for sharing your story. So I am originally from Ireland, born and bred in Dublin, and then found my way to Canada about 15 years ago. Shortly after I moved over and started working as an emerge doc, I started working on acute aortic syndrome, which is the umbrella term which encompasses aortic dissection, intramural hematoma, which is a bruise in the wall of your aorta, or a penetrating ulcer, which is essentially an ulcer in the wall of your aorta. And they all present similarly, have similar challenges to diagnose and time-dependent nature of them. So they all get lumped together under the term acute aortic syndrome. The challenge from an emerge doc point of view is that it's rare and it can be fatal if it's missed. So it keeps us up at night. It's scary. But unlike other scary diagnoses, we don't have a solid reproducible way to either decide who we should investigate or who is at such low risk that we don't need to do anything further. So the combination of dangerous, rare, and lack of reproducible tools means that the miss rate over the years is being higher than what we would like. And it's certainly higher for more common dangerous conditions like heart attacks.
Yeah, I was actually mentioning to Brian earlier that, one of the last cases of dissection that I had was a person who came in with chief complaint of leg cramping. And we thought it was actually substance related because the person had admitted to cocaine use. And so, there was leg cramping and just the typical treatments. The story just didn't make sense. So I eventually put him in the scanner. And that's where we discovered that he had, the stem to stern dissection. And, he did well and recovered fine. But, it's one of those things that if it was just like the books, if it was the tearing chest pain from the chest through to the back that kind of starts to work its way down towards the abdomen, just like our textbooks talk about, it'd be a lot easier to pick up. And then we're seeing this very different presentation. Of course, each human's expression of how they experience pain is different. The description of that pain is different. And so, it does make it very challenging, especially for one that we as most emergency physicians, it may only see, depending on your setting, it may be every couple of years, it may be once or twice a year, but it's not going to be like your STEMI cases or your acute coronary syndrome that you're going to see, basically at least almost every shift or every other shift. So talk to us. You've been working on some of the clinical decision tools or guidance and point of care related resources for ACEP. Talk about those a little bit and how these can potentially assist physicians on something that is relatively low frequency but high risk.
Yeah, absolutely. So working with ACEP and then the Ritter Foundation, tried to put together some practical tools and guidance for the on-the-ground emerge doc, whether you work in a large quaternary care emergency department or whether you work in a community setting that doesn't actually have access to CT. And really, The nice part about it is that the majority of your power is in a solid and complete history taking. You're looking for the breadcrumbs. You're looking for the little data points which raise your suspicion. And it's the simple things. It's the things that you're taught in med school, but we often forget in a high-tech world with CAT scan, MRI, point-of-care ultrasound, blood tests. But the power is in the history taking. The key is really asking and documenting the relevant pain features, the risk factors which increase the patient's risk for an acute aortic syndrome, and then the physical exam findings which give you clues that they've actually suffered this dangerous and rare condition. And it's not rocket science, right? There's a fantastic study from the early 90s, which was replicated in the early 2000s, that if you ask and document your high-risk pain features, your chance of missing an acute aortic syndrome drops, and it drops down to less than 1%. So the key is asking and documenting the high-risk features. And those are the ones which you would have learnt in med school. It's asking about abrupt onset pain. The pain, the characteristic pain associated with an acute aortic syndrome is that pistol onset. The pain goes from 0 to 50 very fast. Now, not everyone will have this, but what you're looking for is clues. So it's akin to when we think about subarachnoid hemorrhage. So it's akin to that thunderclap onset of pain. So number one, ask and document abrupt onset pain. The second one is severity. It is usually a severe pain. And some patients describe it as the worst pain that they've ever felt. So abrupt onset, severe or worst pain you ever felt. So which overlaps a lot with the subarachnoid hemorrhage. So abrupt onset, severe pain, and then radiating pain or migrating. Because the initial point of a tear may be in the chest, but as that tear unzips the aorta, that pain may migrate. And it can migrate anywhere along the aorta or its branches. So it can go up into the neck, it can go down into the belly, to the groin, into the legs. So pain which migrates or radiates. And then the last one is the tearing or ripping pain. But as you mentioned, Ryan, it's only about 1 in 3 patients or less will actually describe it as tearing or ripping. So helpful if it's there, not super helpful if it's absent. So simple, like take your solid history on your pain questions. And if you have any one of these things, then unless you have an alternative diagnosis for that patient's pain, so if you do a workup for a heart attack for acute coronary syndrome and it's positive, then you proceed with that. But if your workup is negative and they have any of these high-risk features, you need to do something else. And we'll talk about that a little later on. So pain features, risk factors, again, it's anything which either weakens your aorta or puts somebody at risk. And so that may be a recent aortic manipulation, that may be previous aortic intervention, it may be a history of an aortic aneurysm, no matter what the size. And then there's other features, like you'd mentioned there, that sympathomimetic use, so such as cocaine. So these things are going to increase the aortic stress or decrease the strength of the aorta, which is going to predispose somebody to having an acute aortic syndrome. And then the last big bucket is the physical exam findings. So signs that the aorta has unzipped and is blocking blood supply from the aorta to some of your major organs. And so that's going to be a pulse deficit in the limbs. That's going to be a neurological deficit. That's going to be a new aortic murmur if it's unzipped and it's loosened the connective tissue around your aortic valve. Those are the big things. And the last one would be hemodynamically unstable, so hypotension or shock state. And that can be through a contained rupture, or it can be through blockage of major blood vessels supplying organs leading to a shock state. So pain features, risk factors, physical exam findings. And probably the two ones which I probably should draw special attention to in regards risk factors is family history and then connective tissue disease. So family history is one that we often forget about. But asking a patient whether they've had a first-degree relative which has had an acute aortic syndrome or a history of an aneurysm is super powerful, because if you have a first-degree relative that has any aortic issues, it increases the probability that this patient in front of you is suffering from an acute aortic syndrome and should trigger you to proceed with further investigation. And then the connective tissue disease is the other piece.
I'm jumping in because you hit the nail right on the head there, Dr. Ohle. Because I'm living proof of that, and I learned that later on because my mother died in 2004 suddenly. My dad did not want to do an autopsy, so they chalked it up to heart arrhythmia brought on by hypertension. But my first cardiologist, Dr. Andrea Tackett, she's up in Seattle now, who was amazing, said, your mom could have dissected, because I did genetic testing at Stanford. I did not have any of those genes, but I wish if we would have known what, that whole thing, you go back, hindsight's 2020. I wish I would have gotten myself checked at that point when my mother passed, to see, wish we would have done an autopsy, but at the same time, I wish I would have gone through, because there was probably signs there because of that. I was probably predisposed to having this dissection that I did years later. So, and I swear by that now, because it didn't, make any sense to me at the time, but now it does. So I think that's spot on, especially for people out there. I say it now from my chair because of my experience, but I always tell people now is make sure you know your family history and get to talk to your family and loved ones after, if you survive, and hopefully you survive, you'll be able to go back and talk to them and spread the word so they can go get themselves checked. And like for me, I have an older sister, so I had to have her go get checked, and my niece and nephew, and all those kind of things. So
yeah, that's a good point, is, checking out that family history. Example being, my wife had a shoulder surgery, developed a DVT in that arm. Another family member, parent, ended up with a couple of months later with a DVT. And we're like, that doesn't really make sense. And so then we start looking at that piece of information in terms of that genetic possibility. So it is, and unfortunately, I think a lot of our morbidity and mortality aspects of things in this country or around the world, we put a little bit too much credit to arrhythmias and acute coronary syndrome instead of, because we don't always know. As in emergency medicine, when I say, cardiac arrest or whatever, there's a lot of things that could have led to that. And I'm pretty sure that most people aren't just like, well, it's going to be probably dissection. I think most of us with chest pain and sudden cardiac death are going to put either acute coronary syndrome or pulmonary embolism first. And so it probably does have a little bit more of a prevalence than we realize. And that's it's important to kind of dive into those things. If your family has a history of sudden cardiac death or unexplained death that's younger than you would expect, then it is worth investigating to see if there is some genetic predisposition or family history of something that needs to at least be monitored down the road. It doesn't necessarily mean an intervention right away. It just means, start looking for things that may not always be on the table, but we should probably move closer to the table because of the family history. I think, Brian, absolutely with your mother's situation, I think it is a very high likelihood that that she passed secondary to a dissection or an aortic related syndrome. So Rob, let's dive into that. We've got the story, we got the history, the things we're looking for. Now, as emergency physicians, what do we need to do about it when we raise that index of suspicion, keep a wide differential diagnosis, and start working towards a dissection?
Yeah, there's different guidelines out there. ACEP has got a clinical policy statement. The European Society has a aortic disease statement in regards to diagnostic workup, and the AHA also has an updated aortic disease guidelines. And they're relatively well aligned now with the recent update, and it's essentially saying that you should take the information that you've gathered and assess, are they a high probability or not high probability. If they're high probability, you're going straight to the scanner. And so high probability means that you've got lots of the pain features, you've got risk factors, you've got physical exam findings that do not pass go, do not collect $200, go straight to the scanner. The important point is that if you don't have a scanner, then you're transferring that high risk patient. And then preferentially, if you have a high index of suspicion, to an aortic center. Now, the tricky part becomes in everybody else. So somebody that has some features, but you're not sure. In those ones there, you have options depending on the resources that you have available to you. You have the option to, again, go to a CAT scan, or you have the option to further risk stratifying with either getting a D-dimer or using point-of-care ultrasound if you are trained to do so. So D-dimer, a lot of controversy around whether you should or should not use it to help risk stratify patients for acute aortic syndrome. And there are caveats. And if you're looking for more information, I suggest you read the ACEP clinical policy statement. But essentially, if you get a D-dimer and that D-dimer is negative in your low, moderate risk group, then the chances that that patient sitting in front of you has an acute aortic syndrome is exceptionally low. And as per the ACEP clinical policy statement, unless there's some other reason, they do not require further investigation. If that D-dimer is elevated, then you go to CAT scan. Point-of-care ultrasound, another very powerful tool to allow you to collect additional information to either raise or lower your probability. Very good study out of Italy, the Profundus study, which looked at the added value of the acute aortic dissection detection risk score, which is a pretest probability assessment tool, and point-of-care ultrasound. And in the hands of somebody that's trained, taking good history, physical risk factors together with point-of-care ultrasound can lower your probability of dissection below your testing threshold. So essentially, reducing the likelihood that that patient sitting in front of you is actually suffering from an acute aortic syndrome. So you have options. High risk, go straight to scan. Low, moderate risk, then you can either get a D-dimer, use a point-of-care ultrasound, or go straight to scan.
And I agree with that, because it's the other thing I would suggest is that if you got the suspicion, get the whole thing. In my case, with the guy with the gentleman with the leg spasm, I only got CTA of the lower, looking for something down there, an occlusion really more than anything, and then end up sending him right back over to get the rest of the arch and everything else. So if you've got that high suspicion, just go ahead and knock out the entire thing. You got one bolus, get it done. So what do we now? We've got him over there. So we got Brian over there, and we've discovered that his aorta is given up. It's started to add another lane to the highway. What do we need to do once we, kind of get that information? What are the things we jump on right away? Because now the management and interventions are becoming incredibly time sensitive.
Yeah, absolutely. I think there's two kind of major goals. How do you get to definitive treatment? And then how do you do your best to ensure, if it is a dissection, that it's not propagating any further than it already has? So from a definitive treatment point of view, depending on where it is, it's either different centers have different pathways. Some have you activate your code aorta. And so you have an aorta team, which is together with your cardiothoracic and your vascular and sometimes your interventional. But essentially, you're calling and activating your surgical team, be that cardiothoracics or vascular surgery, because in the emerge, we cannot fix this. And so you need emergent reviewing of the scans, surgical or non-invasive interventional planning to be able to fix the aorta problem. So that's the most important, is definitive management. Second to that is really, how do you stop the propagation if it is an acute aortic dissection? And it's all about reducing the stress that the wall of the aorta is experiencing. The way I think about it is, I'm a simple person, so it's 5, 4, 3, 2, 1. So the 5 in my mind is giving something for pain. So say 5 of morphine, and it's about reducing that sympathetic drive, which is going to reduce your heart rate and your blood pressure, which is going to reduce the pressure that the aorta is feeling. The 4 is I give 4 of ondansetron because there's usually a visceral component to this and some nausea. So reducing that nausea is going to, again, reduce your sympathetic drive, reduce the stress on the aorta. The 3 is 3 calls to surgery. That's either cardiothoracic or vascular, getting them on the line. In Canada, we use labetalol for the heart rate on blood pressure control. In the States, there's different medications which are used, like nicardipine and other IV medications. But it's essentially you're doing a beta blocker to reduce your heart rate down to a target heart rate of 60. And then the 1 is you're repeating any medication. For labetalol, I give 10 milligrams, Q10 minutes for a goal systolic of 110. And the other part, which we often forget, we always jump to medications to help control that sympathetic drive, but it's actually sitting down at the bedside with the patient. So with Brian, explaining what the diagnosis is, that you got them, and that we're going to get the experts involved. The biggest drive of sympathetic surge for a patient who's experiencing a diagnosis is the stress and anxiety of being in an emergency department, whisked over to the CT scan, everybody looking really worried. And then you have somebody's heart rate going crazy. So you're giving all these medications to decrease their heart rate down. But sometimes just pausing for a moment, sitting at the bedside and saying, hey, man, I know you're scared, but we got you. We're going to get you taken care of.
Could not say it any better. That was the folks at French Hospital. It was go time. It was quick, but so many people stepped up and tried. Okay, hold on, you're in good hands. We're going to get through this, and it really helped, especially when you're by yourself for that moment, because everything was, you didn't think it was going to be anything but anything, and then it was. But yeah, I can't say that, and especially after the aftercare too, because I think with you guys are saving our lives, and then the aftermath of that, and we're still here. We still don't know what's going on, and we're still nervous, and we're still scared, and all those things. And you guys, my current cardiologist is a perfect Dr. Jared Salvo in Bakersfield, California. He's amazing, and just those things that I can call him up or send him a note, and he's, hey, you're good. We got this. So it's so important in every way, because the anxiety is real. The anxiety is real.
So Rob, I want to review your 5, 4, 3, 2, 1 rule, because that's a nice one. So the 5 of morphine, 4 of ondansetron, 3 calls to surgery. Then your 2 is your BP and heart rate management control medications. And then your 1 is what I'm taking is kind of that repeat until we get our heart rate and blood pressure to that right number. Did I get that right?
Yeah. Sometimes it started off at 6 because goal heart rate of 60. In order to get there, you get 5 of morphine, 4 of Zofran, 3 calls to surgery. You give 20 milligrams of labetalol, Q10 minutes for a goal systolic blood pressure of 110.
Yeah. So you got a 6, 5, 4, 3, 2, 1. So it's, the important piece of that, but it is, the importance of that rapid onset. And so, Rob, how can people get information? You worked with ACEP on this guidance. How can folks get that information, and physicians kind of refer to that?
Yeah, so the ACEP has point of care tools, and Ritter and ACEP work together to develop the essentially the Ritter tool, which is a summary and amalgamation of that risk factors, physical exam, how do you investigate, what do you do when you diagnose. So it's a really nice short review of everything that you need to know to be the best person to diagnose an acute aortic syndrome on your next shift.
So, Brian, give us a little breakdown on how folks can get in touch and get more information about the Ritter Foundation.
Yeah, actually, right to the Ritter Foundation website is one-stop shopping. It's absolutely perfect, and I should have it memorized, but I'll give that to you in just one second. But the johnritterfoundation.org right there. So super easy to go to for your resources. And again, for those who are survivors like myself, for friends, for family, for doctors, and first responders, and all those kind of folks that want to have that information. It's a great resource to go in there. How can you help? How can you understand what's going on? And it really helps in so many ways, because I think what you guys are well too aware of, again, is that what you guys were just talking about is identifying and seeing that those cases, so we can, before we get to where I was, we can prevent that, and people can understand and take that stress off the aorta, so you don't get the tear, or at least mitigate some of those challenges that you get before the dissection happens. And I freely, I'm on, survivor group websites and just people talking, and I think that's also a great resource for people as well, on things to have commiserate, because a lot of us, not everybody, but a lot of us, I didn't have anybody that I could talk to about, like, how was your zipper scar, and what happened with you, and compare notes and things like that. You just don't have that ability to have that support. And so it's great to hear from two people like yourselves, again, because I'm learning still more and more, so I can educate myself better, and hopefully help others.
For those that are, so now we have a young generation of physicians coming in training that probably didn't know John Ritter. I grew up with John Ritter during the 80s and 90s. He passed away on the second anniversary of 9/11, so September 11th, 2003. He was one of our frequents on television during the 80s and 90s. So most students now, probably students and young physicians, probably know John Ritter more for how he passed away than what he did before that. So it's a good chance to kind of look back and look at somebody in the situation, the stuff that happened afterwards with regard to malpractice risk and those types of things. It's important information, and I appreciate you both. But before I close any podcast, of course, I don't ask all the questions coverage, so I'll make sure I give an opportunity for any closing thoughts or message. And so, Rob, any closing thoughts, message, or anything we may have missed?
No, I think the patient has the answer about what you should do. So stop, listen, ask your pain questions, risk factors, physical exam findings. And then if you have some suspicion, proceed with further investigation.
Yeah, my one would be, just know your family history, understand it. We don't go to the doctors as often as we probably should to get things checked out, to make sure we're good to go. But for those folks out there who are listening, just make sure you just go and check with your primary care, and then whatever, and go from there. But the thing is there's some great people out there, and I'm meaning doctors like yourselves that are out there and doing this on an everyday basis, and I truly can't say thank you to enough for all those out there who are doing that.
And I appreciate you both. It's going to easily be the first time I've ever had an Irish-Canadian emergency physician on the podcast before. Has also had as well as a survivor that has, for those that are listening into the podcast, Brian's got his Rose Bowl emblem on his left chest there. So I was there actually at the Rose Bowl way back in the 90s, and a great experience, and I appreciate everything, and I'm glad you're around to help continue the game and the world of sports and promotion. So appreciate that, and Rob, thank you so much. And as for me, you can contact me, rstanton@acep.org, rstanton@acep.org. I encourage everyone to check out the Ritter Foundation, as well as the clinical decision tools regarding the Ritter tool with regard to aortic dissection. Again, not an everyday type diagnosis we're going to do in the emergency department, but one where the emergency physician is truly the gateway between life and death. Because if we miss it, we're likely going to lose a patient. And if we catch it efficiently and dive in, there's a a very good chance that we can get that patient stabilized and into a better place. So this is a great opportunity for us as emergency physicians to do what every one of us put on our personal statement, which is to be there to help people and to save lives. And so here's your opportunity. Dig into it, make sure that you are aware, and then we're getting you the tools to help make it happen. I also encourage you to subscribe to the podcast on your favorite player. Encourage your friends, your colleagues to do so as well. Leave us a 5-star rating to boost us up the list. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.
If you're not on the front lines, you're on the sidelines.
Cue the music.
Bow, bow, bow.
Ding. Quiet place, all
Yeah.
alone. Da, da, da.